And now we begin talking about patient assessment. This is the most important thing that you're going to do. When you're looking at that very basic patient assessment, it always starts with scene size up, and that begins from the moment you get the call. So you get your call, you're listening to what they say, you're already assessing to see, do I need additional resources? Do I have enough people coming? What am I hearing? Do I know my area? And I know that certain things are in the way, or it's a specialty, so it's a train track, it's a hazmat facility or something. So just making sure that I have all of my scene resources headed to me. I'm going to do my primary assessment, I'm going to get my history taking, my secondary assessment, and my reassessment. So with our symptoms, we have that subjective condition that the patient feels and tells me about. The symptom is what the patient tells me. The signs are the objective conditions that you can observe and measure. So this is what I see. So signs, I, and symptoms, patient. As we're going in, we just have that situational awareness. I've already got a pretty good idea, hopefully. But these change. It changes as you're pulling up. So you're doing your situational awareness. You're ensuring that your scene is safe. Guys, if your scene becomes unsafe, leave your gear and get out. We'll get gear back later. Don't worry about that. The main thing is that you are safe. If the safety issue, if you can still get the patient out, that's fine. If the patient is the safety issue, that's fine too. Just leave them. We'll come back and get them later. So one of the first things you're doing is you're determining your mechanism of injury or nature of illness. And that can be challenging sometimes because your dispatch information is not what it originally was supposed to be. I got dispatched back in December for a unknown problem mandium that progressed to a pedestrian struck. That ended up actually being, once I got there, figured out what was going on, it was a hemorrhage call. But it did look like the guy probably had got hit. So they had ended up putting a tourniquet on. But what had happened is his shunt from his dialysis had an aneurysm in it and it ruptured. So there was blood everywhere. So they thought it was a trauma. So you see where that changed very quickly. And of course everybody's like, you want to go, you want to go? I was like, no. First of all, I need to work on stabilizing my patient for just a minute. And number two, I need somebody to really find out what's going on before I can leave here. Because without a good story, it's very difficult to take care of my patient. So once it came back, mechanism of injury and then our nature of illness. So I had the combination going on there. Chief complaint. What does the patient complain of? And some of your patients will have 1 or 2 complaints. When they hit about 4 or 5 complaints, I'm like, okay, this is not a me I can fix right now. Now trauma. Trauma's going to have multi-system trauma sometimes, so they do have lots of complaints. But, and you may be finding lots of things, but they only have 1 complaint. So this is another piece of it. You keep finding things. Always make sure, even before you step off that ambulance, that you have your personal protective equipment on. Now we're all wearing masks coming off anyway, but make sure you have your gloves, you have your masks, depending on what you're going into. I may have goggles, gowns, booties, whatever it is that you need as barriers. Make sure you're taking your standard precautions. Determine how many patients do I have. Try to do this very quickly. If you already are hearing you're going to a motor vehicle crash, you have 6 or 8 patients. Go ahead and start sending me some more trucks. I can always turn them away. If fire gets there and it sounds like you've got several critical patients, you may call in helicopters or a helicopter, depending on what your protocol is in your area. So determine your number of patients. With multiple patients, you're going to be using your incident command system. So consider your specialized resources. You're going to do a quick triage. So don't make triage hard. Are they walking? They're green tag. Are they unresponsive? They're a red tag. Are they anywhere in the middle? They're a yellow tag. That's a very quick way to do it. Then I can come back around and now let me get a few vital signs and we'll take it a step further. With our primary assessment, I am looking at my general impression, my level of consciousness, identify my life threats. So my airway, breathing, circulation, major hemorrhage, and I'm going to correct those. This is when I actually would stop and fix something, because if I don't stop and fix any one of those, the patient's going to die. And there may be times, it's not often, but there are a few times you may not get past airway, breathing. You can't even get to circulation because airway's compromised. Well, I haven't got past airway to get to breathing yet. So, get our assessment piece of our AVPU as we're looking at level of consciousness. So are they awake and alert? Are they responsive to verbal, responsive to pain, or completely unresponsive? So our methods of gauging whether a patient is responsive to painful stimuli, we gently but firmly pinch their earlobe, press on the bone above their eye, not their eye, above their eye, or gently but firmly pinch the muscles of the neck. So see if you get a response on any of those. With orientation, if they are alert, now I want to know, are they alert? Do they know who they are? So person, place, do they know where they are? Time, and time can be time of day, time of week. Elderly people can't tell you what day of the week it is because they're retired. My dad still don't, other than knowing Sunday, it's time to go to church. When they're retired, they don't know. And then events. Can they tell you what happened? Or are they completely vague? They don't have a clue what just happened. So I've lost something there. So that tells me, okay, I need to worry about a head injury. Breathing, circulation, we're going to assess those and make sure you read through those because we'll go into more detail. With circulation, I'm also looking at my skin color, temperature. I want to see cap refill, especially cap refill in pediatrics. Very important. Of course, if I find any blood, if I see coagulated blood, I want to make sure I stop and take care of that. As I'm looking in my quick rapid exam, I'm looking for my DCAP BTLS as your mnemonic. So deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. So as you go through, do you see anything outwardly that puts up red flags of, okay, this could be bad? Or is it, okay, I'll note that's there, I'll come back to it. And we do that often. When you're coming up to a patient, another thing to remember is if they're lying supine on the ground, come from their feet. Because if you come at their head, this is what they want to do. And they want to look over and see, well, if they have a neck injury, you just compromise C-spine. So try to come from their feet or at least come around to their side where they can see you, and all they have to do is move their eyes. As we're getting into our history taking, we want to try to make sure we know patient's age, date of birth, gender, race, medical history, history meds, allergies, last oral intake. We're going to get our sample, and events leading up to whatever's happened. We'll also do an OPQRST. So onset, provokes, quality, region or radiation, does it go anywhere, stay in the same area, severity, 1 to 10, 10 being the worst pain you've ever had, and then timing. So has the symptom been constant or does it come and go? How long has it been going on, and when did it start? So lots of different things you could ask in there on timing. We're also going to identify pertinent negatives. So I know with chest pain patients, I'm looking for chest pain. I'm looking for, you know, do they have any radiation? Do they have any nausea, vomiting, shortness of breath? You know, they may only have just the chest pain. So pertinent negatives would be they have no nausea, vomiting, no diaphoresis, no radiation of pain. So all those are negatives for that particular sign and symptom. The other thing you're going to be doing is just your critical thinking piece of assessment. So looking, listening, seeing, smelling, all those things are going to be taken into effect here as well. Stories not matching up. A child that runs to you. You know, all these things are going to be significant to you. Special considerations, silence when you're dealing with a patient who says very little, or somebody else is answering for them. They won't, you know, caregiver, family friend, whoever is with them, a significant other, won't let them talk. Ding, 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 ding. On the other hand, somebody that's over talkative. Ding, 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 ding. It's like, okay, hold on. Something just ain't right. Looking at multiple symptoms, anxieties, anger and hostility, intoxication, crying, depression, confusing behaviors or histories, limited cognitive abilities, and sometimes that's where you may have to have family and caregivers help you. And a lot of times they may know better than you will what's going on too. And then cultural challenges. Where I come from in Guilford County, we had 72 different languages. So there were times I had to stop and make sure, was it okay if I came in? And then as a female, was it okay if I took a blood pressure or, you know, checked for a pulse and that kind of thing. So language barriers can be problems. We have to figure out how to handle those, as well as hearing problems, hearing impairment, visual impairment. So